during the meeting, if you have any questions, also add those to the chat box. I'll try and get to that. Okay, I'm going to kick off the meeting. I'm Vernice Anthony, SEMPQIC, Southeast Michigan Perinatal Quality Improvement Coalition meeting. We're going to do something a little different. During the introduction, we're going to be showing photos of people who have died from COVID. I went to Belle Isle to see the display where they had the pictures of almost 1,000 people in Detroit that had passed away. And sometimes I think we think a lot about the numbers, you know, the statistics, but we don't think enough about the people behind the statistics. And that these are people that are families, these are people that pass away alone without their loved ones. We think about how glad we are when, quote, this is over, but this won't be over for thousands and thousands of people who've lost loved ones as they go through the grief and the pain and not the inability to celebrate and even have what we would have called a proper funeral. So these pictures will just be going through. I see Marlo Stoudemeyer, some of you may know him. He worked at Henry Ford Health System, was quite an active community leader and a young man. It was not just old folks. You'll see pictures of police officers, as we lost many police officers, some very vibrant seniors you'll see pictures of, as well as some children. So again, welcome to the SEMPQIC meeting. This is our last meeting of this fiscal year. So we're glad that you're able to join us. At the end of the meeting, we'll be sharing many of the things that we've done or you've done through SEMPQIC, as well as we'll be sharing where we're going next year. So I want to just quickly introduce the other team members, team leaders. Our Dr. Iris Taylor is here. I see Iris. Olivia Carr.
Could you please mute yourself? Thank you.
Lethea, I see Lisa. Hi, Lisa.
Hello.
And Devin, that helps us coordinate everything we do. And we call Dawn Schonefeld one of our team members who works with the state, but is also very active as a leader. Again, we have a pretty packed agenda, so we're going to try and stay on schedule. You'll be hearing some updates from the state, from Dawn, on COVID, as well as MyAIM. As you know, MyAIM now, we have a leadership role with MyAIM, and we want to be sure that you're completely up to date on that and engaged as you should. We have a wonderful collaborative opportunity. So you'll be hearing from Gwen Norman from Wayne State University School of Medicine. We're excited about that. The major meat, if you will, of our meeting today is going to be a home visiting needs assessment updates for our Southeast Michigan counties, Wayne, Macomb, and Oakland. They've completed their needs assessments, so we'll be getting reports on those. And then, of course, updates as to what we've accomplished, thanks to all of your hard work and participation, and where we're headed for 2021. You see Isaac Robinson there. He was a state legislator that we lost during, and we're continuing to lose people. I'm talking like it's over, but it's not, because while there are fewer deaths every day, there are still deaths every day. So the other thing that I'm going to do this morning or this afternoon is I presented yesterday at the Michigan Health Policy Forum conference. And my topic was, or their topic was, when racism intersects health. They had over 700 people participating, and I was pleased to have the responsibility to talk about the evidence from maternal and child health. So I'm just gonna spend about 5 minutes going over a few of the slides that I shared there. Some of this, obviously, you guys will know because you are maternal and child health. But there is new research that's out now that we're all taking advantage of, which I believe we have sent to you individually or one at a time along the way. So I really like this picture of these two little boys, one black and one white, holding hands with their masks on, because this is what it's all about. We want to do the job now because as they become adults, we want them to be in a healthy world. Next slide, Devin. One of the things that we talked about yesterday was pregnant women with COVID. And from this slide, these are national numbers. Out of 17,000 pregnant women, and these numbers are pregnant women from January 22nd to September 1st. 3,600 were Black and 7,600 were Hispanic or Latino. So about 65% were people of color, or women of color. So again, you know, you see the discrepancy there. Dawn will be talking about some Michigan numbers. But in addition to this, while we don't have all the numbers, there was a recent study done at the University of Pennsylvania, which was really as recent as July, that found that pregnant Black and Hispanic women are 5 times more likely to be exposed to coronavirus than white women. So it stands to reason that we're also seeing a disparity or gap in terms of pregnant women and COVID. Next slide, Dawn. Sorry, Devin. Children, 76% of cases are children of color. The numbers you see here again are national numbers. And you can even see there that 42% of the MIS-C cases, which is the multi-inflammatory syndrome in children, are Hispanic or Black. There have been 1,800 confirmed cases of COVID in children under the age of 10 here in Michigan. Next slide. I had to show this because this is Skylar Herbert. Skylar was 5 years old when she passed of complications from COVID, April 19th. She was the first death of a child in the state of Michigan. And her parents were first responders. Her mother was a police officer. Father was a firefighter. And this was their only child. If this doesn't make you feel deeply, very deeply about the losses from COVID-19, I don't know what will. She's a happy, vibrant, active little girl, the only child of first responders. Her family lived in the city of Detroit. In fact, we have COVID numbers by zip code, and she lived in the zip code, one of the zip codes that had the highest numbers of COVID cases. So, you know, we know from our work that where you live often dictates your health and your health outcome. And that could not be more demonstrated than in the loss of little Skylar. Next slide. Just a few pieces of recent data or research, you know, that further makes our point. And remember, my role at that conference was to provide the evidence from that indicates the relationship between COVID and maternal child health. These two little boys, the little Black boy on the left is a son of a friend of mine, and he had a bone marrow transplant due to sickle cell. And his little friend there is another kid that was also at Children's Hospital that had some other major issues. And this picture was taken at a picnic the Children's Hospital has for their kids. He's perfectly healthy now. And you see they love each other. That's what we're aiming for. This piece of data proved that Black and Latina women were more likely to have severe maternal morbidity than white women in the same hospitals. And the discrepancy was not related to insurance, Medicaid versus private, poverty versus not. The single common denominator was ethnicity. So that tells us, again, what we know, but further confirms the disparities that we're concerned about. Next slide. Now, this piece of information, police violence and the health of Black infants. Wow, I mean, I looked at the website for the Academy of Pediatrics, and they have a huge body of work that I didn't know was there on the impact of police violence. Police killings of unarmed Blacks significantly decreases the birth weight and gestational age of Black infants residing nearby. Wow. Police violence, and we've seen a lot of that lately. Black Lives Matter, whatever, has a spillover effect on the health of newborn infants that really contributes to our disparities. And it also has an effect on the parents or the Black women who, as we now know, have lower birth weight babies and higher maternal mortality. Again, much of it related to stress. The stress points on the families and the children, in addition to the grief of the loss of loved ones, is that there's a constant state of fear. There's a constant state of knowing what's going to happen next in your community. There's a constant state of fear on the part of being, over managed by the police. I saw a really moving video that was on Facebook of a little Black boy playing in his own driveway, playing ball, and he heard a police siren come. So what did he do? He got behind the car so he could not be seen by the police as they drove by, even though he was only playing ball. So when you see these incidents of police violence, this chaos and demonstrations and reactions that we're going through, please know that they're impacting our work and the lives of the very babies and mothers that we're trying to save. Next slide. This one was really a surprise to us. Physician-patient racial concordance and disparities in birthing mortality for newborns. This was quite recent, and I believe we actually sent it out to our network. Our researchers found that when compared to white infants, Black newborns were half as likely to die when cared for by Black physicians. It was like, wow. This difference suggests in birthing mortality can be improved by racial concordance with the physician and newborn patient. More simply said, Black newborn patients that are cared for by Black physicians have twice the opportunity to live than if cared for by white physicians. Now, who would have thought that? That would never have occurred to me. It has a lot to do with things that we're talking about, implicit bias, racism, whether intentional or not intentional, all the things that we are focusing on within SEMPQIC. And we all know that we need much greater diversity in healthcare providers. We need a much greater proportion of particularly African-American providers. In the study, as I was reading the detail, it was suggested that perhaps the African-American physician would have a better understanding of all the issues that the family might be dealing with and approach the care a little bit different. than a white physician. And in the same study, it was interesting that they did not find this as far as OB physicians were concerned. For women, there was no disparity that related to the race of the provider. But indeed, this is something that we need to be paying attention to. Next slide. Social determinants of health. We know what those are, but I'm going to move on because I'm not going to describe those. But I will say, next slide, that the social determinants of health is really the outputs of racism, which is the systemic oppression of a racial group to the social, economic, health, and political advantage of another. Housing, access to food, access to clean air, access to health care, all of the things that we try and work with our clients, social determinants of health, is a result of systemic and structural racism. And if we are the public health providers and the providers that we know we should be or would desire to be, we have to get serious about systemic racism. And we have to be a part of dismantling racism in whatever ways that we can. So I was very pleased that Governor Whitmer identified racism as a public health crisis, as well as creating the task force that's dealing with racism and inequities. And some of you are on that task force, and so we thank you for your work. But what we wanted to stress, or what I did stress yesterday and will stress again today, is that I believe as healthcare providers that are committed to Healthy People 2020 are really desiring to see healthier people, have to take, you know, not just a professional, but a moral obligation to help dismantle racism in whatever avenue that we have the opportunity to do that. So those were, next slide. Devin, do I have my little boy?
Yeah, he should be up there.
Is this my last slide?
Yeah, I mean, it's changed.
Okay. This is, oh, I love this. This little boy says, I matter. And who could disagree with that? So when you're disagreeing with Black Lives Matter, you know, this is what we're facing. This little kid right here, he matters. And I know we all believe that, or we wouldn't be working on disparities. So I'm gonna cut it off here, but I had to show him because he matters. He matters, and we care. So with that, I am gonna pass it on to Dawn Schanefeld, MDHHS, our contact and our team member, to give us an update on COVID, as well as my own. Thanks, Dawn.
Thank you so much, Fern, and thank you everyone for giving me the opportunity to share updates and information today. And for the sake of honoring the agenda, I'll be certain to allow ample time for questions and comments. Next slide, please. In Michigan, coronavirus patient information is entered into the Michigan Disease Surveillance System, or MDSS. This is where in Michigan we capture information regarding communicable diseases. As of September 3rd, you'll see that within our MDSS system for the state, there were 578 women with a confirmed diagnosis of COVID-19 while pregnant. Below this number, you can see where the demographics and the breakdown of each of the individual patients or women lies. Predominantly, the cases were found where you probably would expect women of reproductive age between the ages of 20 and 39 years. Racial breakdown for this data only shows that 49.5% of the women were white, 28.9% were Black, and 21.6% were listed as other. This could be due to the moms being multiracial. It could be due to the information not being entered into the system. And it's important to point out that based on this information, and I'll continue talking here in a moment, but we aren't able to determine the disparities that that are maybe present, and I would say that they are present in the 578 women confirmed with COVID-19 while pregnant. And that's due to the fact that the information that Vern shared previously on COVID-19 numbers, that was from January to present. The cases within our MDSS system for the state of Michigan are from when COVID-19 was first realized in the state of Michigan, so in March, until now the present, as I said, in September 3rd. And we don't have the birth data for that time period in real-time availability in order to calculate the disparities. But we well know, all of us, that we see disparities existing in all realms of health and social care. So most definitely there are disparities existing in this data. And as we're able to share not only the COVID-19 data, but calculate it with the birth numbers, we'll be certain to be publishing the disparity when it comes to COVID-19 and pregnancy. Ethnicity, you can see here that 14.4% of the women were Hispanic and 85.6% non-Hispanic. Next, the cases were broken down by trimester. And you can see that the majority of the cases happen within the third trimester, but there's a good percentage in first trimester and second trimester as well. I also want to make it really clear that this is the information as entered into the MDSS system. So it's entered by local public health and healthcare providers, and as case investigation occurs, as contact tracing occurs, specifically more information is known about the individual cases, then more information is put in the system. So for example, there could potentially be a woman who's been confirmed diagnosed with COVID-19, but she didn't know that she was pregnant at the time that the confirmation was made within the system. And so unless that information is known and the system is updated to reflect the pregnancy, it wouldn't be listed here. Or if there is information entered into MDSS that's incomplete, which sometimes can happen. For example, a positive COVID-19 case is entered in the system, and there's an inability to follow up with the patient for additional information or details. And if that happens, then obviously the case information that's entered in the system is incorrect. But based on what we had as of September 3rd from the state of Michigan, this is the data that's reflected regarding pregnancy. This is such an important topic that I just want to pause here in case there are questions, and you can either unmute yourself or chat your questions in the chat box, and then I'll watch the chat box to answer the questions or see your comments. And I'm going to give everyone just a moment, because sometimes I know it takes time to unmute, and I don't want to cut anybody's question off by moving to the next slide. Okay, next slide, please.
Oh, we got a question here in the chat box.
Okay, good.
What is the total number of pregnant women during that time period?
Yes, Dr. Daly, and that we don't have the total number of pregnant women during that time period due to delay in birth certificate information, and as a result, we're unable to calculate, you know, the percentage overall, as well as the disparities, as I had mentioned.
I was thinking about this too, Dawn. One way to guesstimate, and it wouldn't be, you know, actually scientifically correct, I guess, would be to look at the total number of births in 2018 and determine the percentage of Black births and the percentage of white births, which probably will be very similar in 2019. And using these percentages, you would probably get a pretty good feel for what it is likely to be. I know the overall birth rate is going down a little bit in the state of Michigan, but we don't know what 2020 is going to show. But anyway, that might be one way if somebody just wanted to do a quick and dirty, what might that be? But that other study that I mentioned that showed that Black and Hispanic women were 5 times more likely to be exposed to coronavirus probably gives a pretty good indication.
Absolutely, I believe that it does, Fern. And I will follow up with our epidemiologists and see if we can get a bit more information, because we do know that birth numbers have declined during the pandemic from what was seen, as well as there have been many studies about premature births being on the decline during this time due to there's hunches out there at this point in time, but decreased stressors, the ability to quarantine during the initial stages of the coronavirus. But again, this is all, really unfolding very rapidly. But as soon as I have more information, I'll absolutely share it, and we'll follow up with our epidemiologists to get it. Next slide, please.
I'm
Thanks,
sorry,
Dawn.
this is Lee Griffith. I just want to point out that this number is an under number because so many people were not tested initially due to lack of testing. So I just want, even as we compare delivery volumes, realize that this number is confirmed cases, and there's so many unconfirmed cases out there, particularly the first 6 weeks or so.
Sorry. Can everybody mute themselves if you're not talking?
Thank you. That's a very good.
Sorry about that.
That's a very good. It's okay. That's a very good point. Absolutely. We know that testing hasn't ramped up, as high as we would like it to. Most definitely, that wasn't the case in March, April, and May, when there was a supply and testing shortage. So absolutely. Next slide, please.
Yeah, could you just quickly reiterate what you said about premature birth very quickly, and then I'll move to the next slide. We had a comment about that in the chat box.
Yes, so there was some initial studies that came out and information about the number of premature births declining during this time, and that's being monitored again by the state of Michigan as well. But it was surmised or suspected that that was the result of a few things. And one, most importantly, was the stressors that Vern had mentioned. So initially, when families were in quarantine and weren't dealing with the stressors of going out to work and taking bus systems to and from work, to and from school, were in the cocoon or the safety of their home, and what impact did that have about that decreased stress potentially related to preterm birth. Again, at this point in time, I mean, these are hunches. We're very new in this pandemic, as Vern mentioned. We're still in the middle of it, so we don't have all the definitive answers, because on the flip side of things, we also know that there's been a rise in opioid-related deaths or overdose deaths. We know that there's been a rise in domestic violence. There's concern about child abuse. I mean, so there's a lot of other factors, as well as the economic stress on families when they're not able to meet their basic needs due to the economic downturn of our country as a result of COVID-19 as well too. But those were some of the initial, like I said, articles and publications that were coming out where that preterm birth was declining. But again, we don't know that yet, for certain in Michigan at this point in time. Are there other questions, Devin, in the chat box?
I have something to add, if that's okay.
Yeah, oh, absolutely.
Due to, you did state that we had less premature births during this time. Is that, you think that might be also contributed to the clients not going to the hospital as often for different testings from the doctors?
You know, I wouldn't, we have several physicians on the phone if they would like to, and OBGYNs weigh in on this. My initial thought, I'm a nurse, would be no. But again, we don't know definitively at this point in time, and definitely not in Michigan. But if there are any OBs on the call, which I know there, I've seen a few, if
Yeah,
you
I'm
want to
happy to
weigh in and share your thoughts, that would be great.
Yeah, I'm happy to take the question. I mean, nobody knows, but I don't think there may be some physiology related to the fact that patients were not on their feet as much. So their activity was limited. Many people are at home more. I can tell you anecdotally, I brought this up early up to my kind of colleagues at Henry Ford Hospital because I absolutely saw a decrease in the preterm birth rate and preterm labor, an absolute decrease. So I don't think that patients were delivering preterm at home because we weren't seeing them coming in after delivery. I think there was a decrease in the preterm birth rate. And just as was mentioned, we don't know all the factors that went into that. So actually I had somebody try to pull some data during that time frame, but I cover labor and delivery several days a week, and there was a big difference in what the gestational age of the patients we were seeing.
Okay, it's another question. So you had a decrease in pregnant mommies coming to their prenatal visits also, correct?
That is correct, but if it was related to the prenatal visits, and I'm going to say we had a decrease, right? We were still open for prenatal visits, but yes, a lot of people did not come to the office or to the hospital. But we didn't see people delivering preterm at home. So I think overall, I think it's probably related to the stressor impact and maybe even just physiologically people staying put and not traveling as much, not being on their feet as much. I don't know what the rationale is, but it was an interesting finding.
Yeah, I would be very, very concerned to put out any message that said decreased preterm births was because they weren't going to see a physician. That is a dangerous message to put out. And I'm not an OB and I'm not in an OB clinic, but there really are not that many, if any, quote unquote, tests or things that are done during a prenatal visit that would increase in any way that I know of. Again, I'm not clinical, I'm a nurse, but not a doctor, risk of increasing preterm birth. So I just wanted to put that out there before we got any further. Do you want to continue, Dawn? We're going to run out of time.
Yes, absolutely. Next slide, please.
Mm-hmm.
Okay, I wanted to just give a bit of level setting information. I know this has happened in the past during your last meeting, but just briefly, I just want to cover what the Michigan Alliance for Innovation in Maternal Health is, or MyAIM, before I delve into some of the Region 10 specific MyAIM statistics. So more broadly, AIM is a national quality improvement initiative aimed at improving outcomes, maternal outcomes, both in the realm of severe morbidity as well as mortality. In the state of Michigan, we've seen great strides or improvements in our severe maternal morbidity as a result of the participation in MyAIM. Michigan became a MyAIM state in 2015. There are several areas that we focus on in partnership also with the Obstetrics Initiative, or OBI, through Blue Cross and Blue Shield, and some of the bundles that are being addressed and implemented through birthing hospitals in Michigan are obstetrical hemorrhage, severe hypertension, and safe reduction of primary cesarean births. Next slide, please. With MyAIM in Michigan, I want to draw your attention to the top right of the slide. And this is why we are doing AIM in the state of Michigan, as well as all of our other efforts that are included in the Mother Infant Health and Equity Improvement Plan. So Black women are 2.4 times more likely to die from pregnancy-related causes as white women. And clearly the disparities that we've been discussing, but that exist in maternal health carry over into infant health as well too. So it's critically important that we address the disparities, and we get to, you see number 1 here in the the left of the slide, reduction of racial and ethnic disparities. And we attest to eliminating those disparities. If you see that our vision above for the improvement plan of 0 preventable deaths and 0 health disparities. So essentially AIM is quality improvement efforts that are being conducted by birthing hospitals throughout the state of Michigan to implement evidence-based bundles that improve outcomes for women. And again, those outcomes that we're working to achieve improvement in are the disparities that are existing in hemorrhage and hypertension, in sepsis, and a variety of other areas in the state. If you want to see more information about what specifically Michigan is doing, down here below is our website for Michigan AIM. So it's myaim.us. Next slide, please. As part of the MyAIM work, hospitals who are participating in AIM receive designations. So designations based on a variety of different things, such as implementation of the bundles that I mentioned, participating in educational webinars that are offered as part of AIM, participating in our Mother Infant Health and Equity, or our Mother Infant Health Summit. And if someone's unmuted and has a cute little dog barking, it'd be great if they would mute. And then as well as entering data into the Michigan Health and Hospital Association system. And the data that's entered, we're going to see a snapshot of that from Region 10. So I'm going to go through the next several slides, and this lists all 23 of your birthing hospitals in Southeast Michigan, which again is Wayne, Oakland, and Macomb counties, and lists the designation criteria. So obviously they're all in Region 10, and on the right column you see the designation criteria. I want to share some important disclaimers before we go through these. First of all, Ascension Healthcare has an excellent quality improvement system, and as does many of the hospitals that are going to be listed or health systems in the next several slides. Not having a designation criteria does not mean by any means that they're not doing quality improvement around maternal health. It means for the sake of my aim that they aren't a fully participating MyAIM hospital. And we really would like all the hospitals throughout the state to participate if at all possible. We understand the resource, financial and staffing challenges, but absolutely we really want to have a focus on all of our birthing hospitals in the state, and particularly Region 10, given this is where our highest percentage of babies is born, as well as the greatest disparities existing in maternal and infant health outcomes. So if you'll look down towards the right, you'll see that there is one large Ascension hospital that's participating, and they're listed as bronze, and 2 Beaumont hospitals as well are listed as bronze. Next slide, please. Next, we have a few additional Beaumont hospitals that are all listed as in bronze as well. And it's important to note that Beaumont is one of the health systems that's really geared up to begin participating in the AIM work within the last couple years. Next slide, please. The designation criteria that I'm showing now is from 2019, so I want to point that out as well too. There's obviously a year of participating before the designation levels are revealed, and these were supposed to have been revealed in person at our Mother Infant Health Summit in March, but due to COVID-19 and the summit being moved to being virtual and happening next week, these designation criteria were delayed in being released. So again, you can see the additional hospitals within Southeast Michigan, and I think it's important to give a shout out to the Henry Ford hospitals listed here. You see Henry Ford Detroit and Macomb are both gold hospitals, and then Henry Ford West Bloomfield and Wyandotte are platinum hospitals, with platinum being the highest level of designation. Next slide, please.
Here you go.
Okay, and then these are the final hospitals that we have listed for Southeast Michigan, and you can see that they do not have designation criteria per MyAIM designation standards. However, as I said, quality improvement efforts very well are probably occurring within the hospitals, And as we move forward and try to improve outcomes in Southeast Michigan, I think it's critically important that as many hospitals as possible participate in the AIM work, because the bundles are evidence-based and they're a standard of care that most definitely could improve clinical outcomes within the region. Next slide, please.
Dawn, before we leave this, there was a question of what does bronze gold mean?
Yes, so if there's specific points that are given based on participation. So for example, if you attest to be a hospital that's participating in AIM, you receive points. If you are participating in our summit, you receive points. If you are fully entering data into the MyAIM system, you're going to have a higher designation level. And each of the breakdowns for the point systems are available on the MyAIM website that was shared just a few minutes ago. Or you can go directly to our State of Michigan website, which is michigan.gov/MIHEIP. And if someone from my team would chat that in the chat box, that would be great, along with the AIM website. You'll be able to see the breakdown of the designation criteria. So essentially, there's less participation at the lower levels in comparison to the platinum level. This slide here is a breakdown from that was shared by the Michigan Health and Hospital Association of Region 10 MyAIM data. So as I said, there's 23 hospitals within your region. Of those hospitals, we only have a partial implementation of the bundles that I mentioned, specifically hypertension and hemorrhage. And of that partial implementation, the hospitals are focusing on support for their patients, their families, and their staff, holding multidisciplinary case reviews, which are reviewing cases when there were diagnosis of hypertension and hemorrhage, as well as implementing policy and procedure around both of those areas on the units, on the labor and delivery units. And then finally, electronic health record integration. So making certain that episodes, or beyond episode, but incidences of hypertension and hemorrhage are captured within the electronic health record. The information is entered, and then that in turn is the data that's put into the MHA system. Of the 23 hospitals, this is something, these are areas where we can make, we have great strides or great areas for improvement here. So 4 out of the 23 hospitals in Southeast Michigan actually submitted processed data last year and have some data submitted for 2020. So we most definitely could do better than that. The other 19 hospitals have not submitted processed data for 2019 or 2020. So essentially their designations that you saw on the few previous slides, they're related to signing the attestation form that they're participating, viewing webinars, educational type opportunities. But when it comes to implementation of the process measures or having a policy and procedure around hypertension and hemorrhage, that's where improvement definitely can be made. When we go down further, so data for 2018 and SMM, which I should have spelled out on the slide, is severe maternal morbidity. And so you see hemorrhage here, and this hemorrhage and hypertension. So the first bullet, within the system, so within the hospital claim system, there were 2,839 cases of hemorrhage in Southeast Michigan and 1,934 cases of hypertension. So these are cases that were, as I said, that were entered in the system based on hospital coding, which is why it's critical to have the component above, which is the electronic health record integration for capturing these cases. The numerator that you're seeing for both 810 and 215, these are women that were diagnosed as having severe maternal morbidity. So not only did they have hemorrhage and hypertension, they had complications as well due to the hemorrhage and or hypertension. Examples of complications would be a heart attack, an aneurysm, acute renal failure, respiratory distress syndrome, cardiac arrests, needing to receive ventilation. All of these would be considered severe maternal morbidity. And so if you look at hemorrhage, of the hemorrhage cases in Southeast Michigan, 28.5% of the women had a severe maternal morbidity complication, and 11.1%, again, that were diagnosed with hypertension, had severe maternal morbidity. Those numbers are percentages. I want to remind you all of the slides that you saw at the beginning that Vern shared of family and friends that died of COVID-19 in Southeast Michigan. These are women, these are moms. And so each of the numbers in the numerator is somebody's family member. Those numbers are extremely high and prompt us to do much more as quickly as possible when it comes to assuring a standard of care for addressing hypertension, hemorrhage, and responding to it. You'll see the breakdown here as well, based on breakdown by race. But again, I'll make certain that we get additional data from MHA and our vital records area, because we aren't able to see disparity. But I think we all know that sadly the disparity exists in these outcomes, and particularly based on the slide that I previously shown, where it showed the disparate rates in maternal and infant or maternal outcomes when it came to pregnancy-related complications. Next slide, please. Next, I just want to transition to share an update on infant mortality rates by prosperity region, and particularly prosperity region 10, broken down by the region, by the city of Detroit, and Outwayne area. And so if you look across from left to right from 2010 through 2018, and 2019 should be out shortly too, I want to point that out, you can most definitely see that there's increases that have been happening. I mean, from year to year. And I'm not an epidemiologist, so I'm not going to make any statistical summary, but all you have to do is look at the orange bars right there for the city of Detroit. In 2016, 13.3, then 2017, 14.2, 2018, 16.7. That's not going in the right direction. And the same holds true for just prosperity region 10 in general, if you look at the blue bar. So it's just important. I wanted to share that and let you know that we'll have updated 2019 information really soon. But it's critically important, the work that you all do, that we continue to do that, because again, as in the Burns presentation, we shouldn't have multiple bars. There should be one bar, and not variations throughout the state, variations based on race and ethnicity. That should not be happening. Next slide, please. And I just want to wrap up quickly because I know that I'm over time. So a few additional updates. The updated version of the Michigan breastfeeding plan will be released later on this year or the beginning of 2021. The Mother Infant Health and Equity Improvement Plan Year 1 highlights will be released next month. It's with our communications department being approved. And I just want to you'll see when it's released, but kudos to everyone. Even in the midst of a pandemic, we've made great strides here in the state of Michigan, coming together and doing great work to lay a foundation to eradicate racism and the inequities that are existing. We are further at the state aligning fetal infant mortality review, or FEMR, and maternal mortality surveillance. Our team embarked upon a lean process improvement last year regarding the FEMRs across the state that are primarily housed in local health departments. Right now, we're kicking off another LPI process, or lean process improvement, to further align the recommendations process that occurs between FEMR and maternal mortality surveillance. And importantly, getting those recommendations to all of you in a timely manner, and creating recommendations that are actionable that we can create systems change with. And so please know that you'll be seeing and hearing more about this in the very near future. And then finally, I just want to give a shout out to the families of Southeast Michigan and and our SEMPQIC partner, GDAC, the Greater Detroit Area Health Council, through some great work that they did with Southeast Michigan families. The state has new safe sleep materials. Those can be found on our Safe Sleep website. You'll see it here, michigan.gov/safe sleep, as well as materials that can be ordered from the state of Michigan clearinghouse. That was excellent work and obviously family-driven work. Next slide, please. As I mentioned, our Maternal Infant Health Summit is next week, but we're already preparing for 2021. So I want you all to save the date. The dates for the 2021 summit will be June 28th and 29th. Right now, this is a very, very tentative that will be at the Lansing Center, but we're having a virtual backup as well. Hopefully we're out of COVID, but that's to be seen. It's going to take some time for vaccinations and such to occur. But I encourage you all to visit our website frequently and save the date for that in your calendars. Next slide, please. So thank you all. I appreciate the time. Apologize for going over, but if you have additional questions for me, I'll watch the chat box and I'll respond to those. Thank you, everyone.
Okay, thanks a lot, Dawn. That was extremely informative. I do want to remind everybody that about the importance of my aim. It fits squarely within SEMPQIC and our role. So we do encourage those hospitals that are not participating or getting in the data to really, try to make it a priority. I know you're laughing when I say that, given all the work that you have to do in COVID. But again, my aim has actually proven that it can change the numbers. And while we are, wringing our hands about, well, there's nothing we can do here to make a difference. This is one thing that we can do that's certainly to move the numbers. So, so again, thanks, Dawn. And we will be having reports on my aim at all of our meetings in the future. Gwendolyn, Dr. Norman, we'll move on to your presentation, and I'm just going to ask everybody to just be aware of the time. We did build a little cushion in here, so we're not at a crisis point, but just be aware of the time. Thanks.
Okay, thank you. And I'm going to try and stick very close to 15.
Okay, I'm done. I'm shutting up.
Okay, you can hear me?
Yep, we can hear you.
Okay. So I'm going to try and get through this as quickly as possible. As you know, I wear several different hats, and I'm speaking today as my role as the co-investigator on a recently awarded supplemental grant from NIH from the ECHO project, which is the Environmental Influences on Child Health Outcomes. And the name of this study is Mitigating the Impact of Implicit Bias on Morbidity and Mortality for African American Women. Next slide, please. So these are things you're very aware of. An estimated 700 women die each year from conditions related to pregnancy and childbirth, with the United States having the highest rate among the developed nations, and an estimated 50,000 experience severe maternal morbidity. So in a new initiative to address this, the National Institutes of Health announced the opportunity for investigators to lay the foundation for implementing a maternal health and pregnancy outcome vision for everyone, or IMPROVE. And the acronym IMPROVE is an initiative which is going to support research on how to mitigate preventable maternal mortality, decrease severe maternal morbidity, and promote equity in the U.S. IMPROVE is going to be a multi-pronged, innovative research initiative designed to target health disparities in populations that are disproportionately affected by morbidity and mortality. Next slide, please. So the supplement offered 3 goals from which investigators could choose to focus on, and we chose goal number 1, which is to incorporate community partnerships and participation in domestic maternal morbidity and mortality and pregnancy-related and pregnancy-associated morbidity research to resolve health disparities and to attain equity in maternal health. Next slide, please. So in addition, There were 15 areas of interest to pursue that aligned with these particular goals. And there were 4 that were most relevant to our focus, but I'm only going to read the 4th bullet of the 4 that we chose to work with, which is to develop strategies for enhancing community partnership that engages women and their families, community healthcare providers and systems, and local governments to identify barriers to and community-specific opportunities for optimal maternal health equity. Next slide, please. So we've just been talking about COVID-19, and one of the things you're aware of is that in the midst of this pandemic, individuals have adopted behaviors that are designed to protect themselves from being harmed by the coronavirus. We do social distancing and hand washing, face masks, abstaining from large gatherings, and these are all methods that we know that help to prevent the spread of the virus and keep the virus from entering the body. But in contrast, there's very little known about how to ward off the stress and the physical toll that's caused by acts of bias and racism. Specifically, there have been very few studies to determine how to prevent bias and racism literally from getting under our skin and compromising our health. So while the most common causes that Dawn has just gone over that impact pregnancy outcomes and cause maternal death, such as infection, heart conditions, hypertension, severe bleeding, and strokes, can be prevented or at least mitigated, this opportunity compromised when mothers do not receive equitable care and when moms avoid healthcare services rather than undergo the stress associated with adverse and unfair experiences. So our overarching goal at the end of this, we'd like to be able to empower women by discovering strategies that women can employ to lessen the impact of unconscious or implicit bias in the healthcare setting and thus reduce their risk of maternal morbidity and mortality. Next slide, please. So why is it that we think that this is such an important area of focus? Well, if you look at this first bullet point, you can see that attitudes and behaviors of healthcare providers have been identified as factors that contribute to health disparities. In 2002, I know it was a while back, but it's still relevant today, the IOM concluded that unrecognized bias against racial and ethnic minorities may affect communication with providers and the receipt of care. And most importantly, this review showed that implicit bias was significantly related to patient-provider interactions, provider treatment decisions, patients' adherence to treatment, and health outcomes. And I have this in bold because it's pretty chilling, but it's important to understand that, in fact, implicit bias was more often significantly related to patient-provider interactions and health outcomes than to the actual treatment processes. Next slide. So, without going through all of the literature that led to this summary and these conclusions, we can say that a critical examination of the United States maternal health disparities supports that are in Black women's exposure to systemic racism, implicit bias, and institutional barriers. With Black women being more likely to, 1, be uninsured and receive less preventive and primary health care prior to pregnancy, 2, to die of pregnancy-related conditions at a higher rate than white women with the same conditions, 3, receive lower levels of obstetrical care based on location, and 4, experience racism and implicit bias within the health care system. Next slide. So our hypothesis is that eliciting guidance from community stakeholders, including moms and families, through the lens of reproductive justice, respectful care, and health equity can offer critically important information useful in reducing disparities in maternal health and perinatal outcomes. Next slide. So what we are trying to do is to conduct community-based participatory research to identify interventions to reduce the impact of implicit bias in healthcare that may contribute to increased risk for maternal mortality and morbidity in high-risk populations. So this study is going to engage African-American mothers, community maternal health advocacy organizations, and healthcare providers in a series of structured interviews and focus groups. And utilizing a mixed methods approach and doing content analysis, the data we'll obtain will be used to develop a cool toolkit of specific strategies for mothers to counter negative interactions and obtain patient-centered, respectful care. Next slide. There are 2 aims in this study. The first aim is to identify facilitators and barriers for mitigating the impact of bias and racism on African-American women in healthcare settings based on input from key informants, including both African American women at risk and healthcare providers. So we were going to be conducting focus groups with African American mothers who are participants in our Detroit ECHO group to understand their experiences in seeking prenatal delivery and postpartum care, and to determine how best to optimize effective utilization of healthcare services. Next slide, please. The second aim is to develop strategies that will optimize utilization and effectiveness of healthcare services for African American mothers. So we will have a second round of focus groups and interviews with the same mothers and healthcare providers identified in AIM 1. We will solicit input for developing an intervention at supporting changes needed to end the implicit bias and systemic racism that African American mothers face in accessing delivery and postpartum care, or prenatal delivery and postpartum care. And we will evaluate healthcare providers' experiences with training simulations around implicit bias and all activities completed in parallel with the Atlanta ECHO site. And I kind of just rushed through, but we are working in parallel with the site in Atlanta that's also doing this research. Next slide, please. So for the patient sample, these are women that were in the ECHO cohort in Detroit who delivered in the last 2 years. We're looking to do approximately 4 virtual focus groups with around 10 women each, doing these in 2 phases. The women will be paid $50 as an incentive for completion of the 2 rounds of the focus group. Next slide. And then for the providers, we're also going to conduct semi-structured interviews. We're looking to engage obstetricians, nurse midwives, and doulas who provide delivery and postpartum care in Detroit hospitals where the ECHO participants delivered. Approximately 4 providers, 4 midwives and 4 doulas, who from the 2 major delivery services in Detroit Hospital and St. Grace. Next slide, please. So in phase 2, again, looking at that aim 2, which is to develop the strategy that will optimize utilization, the mothers who participated in phase 1 in the focus groups will be asked to participate a second time, and this time we're going to come back to them with the information they gave us to give us more information about whether what we have developed is going to be something that will be useful to them. For the provider sample, we are going to conduct semi-structured interviews, and these are the ones who are going to provide delivery and postpartum care and participate in the IHI birth equity lab training simulations around recognizing and intervening upon implicit bias. So we want to see what happens after implicit bias training, what they have to say about it, and if that has impact or meaning for them. Next slide. These are basic questions that we would like to be able to answer in the 2 phases of this study. In phase 1, we want to be able to answer what are the facilitators and barriers to equitable and respectful prenatal delivery and postpartum care for African American women from the perspective of the African American woman, and to what extent do African American mothers, healthcare providers acknowledge the role of racism and implicit bias in the care of African American women. Then in the second phase, what do African American women see as the strategies for improving their utilization and engagement in prenatal delivery and postpartum health care, and their ability to adhere to treatment recommendations? And secondly, do providers' perceptions of the role of systemic racism and implicit bias in medical decision-making change following a training simulation? Next slide, please. So we aspire to work collaboratively with both IHI MERC and SEMPQIC, recognizing the alignment, their alignment with shared missions surrounding equity and birth outcome, and the unique contributions of each of these organizations. So in our proposal, we described collaboration with the IHI Birth Equity Labs, which are part of the IHI MERC for Mothers initiative to improve equity, dignity, and safety in maternal outcomes by building upon our current activities with the prenatal birth and the postpartum working groups. Next slide, please. For IHI MERC, we would like to be able to ask with these working groups and the leadership of these groups to assist in developing semi-structured interview guides and pilot the instruments, and then elicit cooperation from community health or advocacy groups to host study presentations, assemble groups to pre-test phase 1 focus group scripts, and conduct phase 2 focus groups with approved instruments. Next slide, please. And SEMPQIC. So in forging this collaboration, we're asking SEMPQIC to provide a platform engaging the representatives from key community and health organizations to do the following. First, to form an advisory committee to introduce the study and support the research, disseminate research findings to clinicians, hospitals, health systems, and policymakers to foster translation and uptake of the findings and move the research to the next stage through the formulation of additional research questions and research strategies to advance maternal health equity, and finally to facilitate the conduct of this community-based research. Next slide, please. So I want to thank you. I'm open to questions. I think I stayed within my time.
Sure. Alethea, do you want to make some comments?
Sure. Thank you, Dr. Norman, for that presentation. As you heard, the information that she shared is really in line with some of the conversations we've had in previous meetings. And because they are looking to develop an advisory committee, we thought we'd open the floor now for those that may be interested in either learning more about what committing to the advisory committee would mean, or know that you're interested in participating as a member of that advisory group, to chat that in right now so Dr. Norman will know, and we'll follow up with contacting you to let you know what the next steps are. I remind you that this is a one-year project, and so, you know, time ticks pretty quickly, and I'm sure she's looking to get started as soon as possible. But we will open the floor to questions. If anyone needs further clarification, if you're interested in participating, chat your name in and your agency, and we'll follow up with contact. Dr. Daly is asking when this officially starts. Dr. Norman?
Yes, it's we are starting now. We haven't taken any actions beyond this presentation today, but to start. So if we can form the advisory committee, have organizations that are willing to work with some of the steps that I described, then we're ready to start now.
Other questions? Okay, we'll leave the chat box open. As you think about the information you've heard, you'll receive the slides that Dr. Norman shared as part of your material from today's meeting. And as you review it and think about this work and the importance of this work in our community, please feel free to either be in touch with Dr. Norman directly, she's got her number here, or contact us here at SEMPQIC. Thank you again.
Okay, and thank you.
Thanks, Dr. Norman and Alethea. We're moving on now to home visiting needs assessment for Southeast Michigan counties, and Dr. Iris Taylor is gonna introduce what we're doing here. Iris?
Iris. Let's see.
Oh, she must not hear me.
Yeah.
Check your mute, Iris.
Okay, Alethea, you can kind of introduce what we're doing here.
Sure, no problem.
Yes.
Over the last, I guess it's been the last 6 weeks, it might have been even a shorter time frame, all the counties have been involved, I have been involved in conducting home visiting needs assessment. And both Iris and I worked with Wayne County directly under Gaylada's leadership to do the work. They had guidance from the state, and we've asked Gaylada to share, well, we've asked all of our counties, Wayne, Oakland, and Macomb, to share some of the highlights of the results that came out of that home visiting needs assessment, mainly because the data is just the kind of information we need to know and understand as we continue our work to address maternal and infant health in our region. So I'll turn it over to Gaylada and leave it there.
I might be missing a slide. Gayletta, I'm sorry, I'm missing your first slide for some reason. So if you want to get started, make sure she's unmuted. No, I see her, but I can't hear her. Gayletta. Oh.
Technology is great when it works, right?
I know.
Want to
Sorry,
start
everybody.
with Jessica or Lisa and come back to Gayletta?
Yeah, Gayletta, maybe try closing out of the meeting and signing back in. I'm going to skip forward to Jessica's presentation, and then we could go backwards.
That sounds good. I'm here. Can you hear me?
Yes.
Yes, loud and clear.
Great, thank you. Hi, I'm Jessica Charm, the LP coordinator for Oakland County. And so I'm presenting on the home visiting needs assessment finds within this county. So I kind of broke up this presentation up by each of the steps. They did give us a short time to complete this project, so it was kind of a whirlwind, especially due to COVID and the ability not to meet in person. We had to be a little bit creative. So next slide.
There you go.
Thank you. So one of the steps was gathering community input. With Oakland County, we had about 2 focus groups, each averaging about 5. We had one English-speaking parent focus group and one Spanish-speaking focus group. So here are some of our key findings within that step. Next slide, please. One of the biggest strength that we found within Oakland County that I just wanted to make sure that I shared was, out of all of the parents that we talked to, the biggest thing that they really felt was having that true, strong bond with their home visitor. It is almost like they are part of the family, especially during this pandemic. The accessibility, the support, the creativity, the ability that these home visitors went above and beyond to reach these families, to make sure that they were supported, to make sure that they knew where the resources that they needed were available. All of them felt that they went above and beyond. They were able to feel like they were providing for their children, that they were in the loop and still connected to the community. Some of the opportunities that we saw was especially through the Spanish-speaking parent focus group, they just wanted more Spanish-speaking opportunities. A lot of times they feel as if the opportunities for them are not out there, a little bit like they couldn't have wouldn't be able to express their needs without finding someone who was also Spanish-speaking. Another opportunity was home visiting services, extending home visiting services past the age of 3. When looking at all of our home visiting programs, a lot of them focus on prenatal to about 3. Many of these families usually transition into a Head Start program or a free preschool program. If that family doesn't qualify, or sometimes, there's other issues, there's transportation issues, whatever it may be, for that child not being able to get into that preschool program, there really isn't that many services available for those families. Another big opportunity is when talking with the parents, they didn't know about what home visiting was until they were approached directly. And another one was more resources for specific specific to fathers. Next slide, please. Key findings and outcomes. One of the great things about having a home visitor, one of the best outcomes is they feel that they can navigate through doctor's appointments and developmental concerns. They know about developmental milestones. They can come up with a plan and follow through on that. They feel more informed. They feel like they ask better questions, and they feel like they can make better decisions for their family going forward. They also feel like their child is ready and prepared when that is time for them to enter into kindergarten. Some other key takeaways from the parents is when we talked about domestic abuse and substance abuse, you know, these are topics that are pretty sensitive. They talked about creating an anonymous informational meetings, and these kind of would be held virtually so that they could protect their information. They also wanted to see more play groups and opportunities to meet other parents, such as those parent cafes, more multilingual home visitors and opportunities. And one of the other key things that they were talking about, again, is the lack of information regarding home visiting programs in the community. Many of these people, you know, a lot of their family and friends don't know about the program, and they felt as a whole, if the community knew about home visiting, more people would participate in the program. And they just couldn't believe all the things that they were able to receive, all the benefits, and not many families around them knew about this. So next slide. So in the next step, we assessed our community risk, and the purpose of this process was to describe the county demographic, cultural characteristics, the outcomes of concern for the county as a whole, evidence of disparities, and areas with elevated risk. So we really took a look at the data in this step. And so I'm just giving you just kind of a brief thing, key things that we found. If you want to go to the next slide. So this was taken from the data from the maternal and infant mental health from ECHO. And if you take a look at the numbers, and this was the most recent that I found, you can see that there is a big drop in numbers for mothers who receive early prenatal care and there's adequate prenatal care. If you look at where the drop starts to fall, it's around 2007 and 2008, which is right around the time that was around the recession, sorry. You want to go to the next slide? And it seems like those numbers never came back up since. We take a look at this data that we found through Kids Count. You'll see that there's worsening trends in less than adequate prenatal care and child deaths. If you can go to the next slide, you'll see that there's worsening again also with child abuse, neglect, children in investigated families, confirmed victims, children in out-of-home. So we're not sure if we're seeing this correlation, you know, since it seems that those programs were the first ones to be cut back in 2002 and 2008, and we haven't seemed to ever recover back from that. You want to go to the next slide. So the key takeaways from step 3 is just the lack of prenatal care is trending high. Does this correlation with the relationship of higher population of young adults who end up in poverty is growing, or child deaths are on the rise? So are we seeing effects now starting? It seems that there's certain issues that are getting worse due to the lack of prenatal care. In Oakland County, African Americans' child infant mortality rate is 3.5 times higher than a white child. One of the things that we also, when we were talking about the data, you know, we were also talking with home visitors and parents, you know, what is something that the data is really not showing? What can we really pull? When you're looking at Oakland County as a whole, Oakland County is it's a pretty affluent county, and overall our numbers look pretty good when you're looking at the county as a whole. But when you start digging into certain areas like Hazel Park and Oak Park, you'll see a huge need that is growing. Oakland County is the largest non-speaking demographic. And there might be a large undocumented immigrants who need home visiting care or care in general that just do not access it because they're afraid. You want to go to the next slide? So then we assess the reach and quality of home visiting, where we surveyed our home visiting programs. Out of the programs, 15 responded back. You want to move on to the next slide? So some of the key takeaways in step 4 is based on the survey data sent to home visiting programs. Not many home visiting programs serve ages 3 and older. And this may have started an issue of transitions when a child might not qualify for a Head Start. So we might be missing that opportunity with families. They might hit that age 3, and then they kind of are out of the loop with resource information until their child broaches into kindergarten. We also talked about MIHP programs having a little bit more difficult time connecting and collaborating with other home visiting programs due to time and capacity. Moving on to virtual meeting setting, I've noticed more MIHP programs have been able to attend, but as you know, as I've talked to a lot of them do talk about the inability to take time to drive to meetings, to be there, and to collaborate. So, you know, that's definitely an opportunity. And then Oakland County does have the need and capacity to expand home visiting programs. Next slide. In this step, identifying the reach and quality of services, we want to identify the referral networks that have developed around each of our home visiting programs. So the next 2 slides are kind of a web and how kind of all of them are connected. And this was surveyed out of the 15 that responded back. So it kind of gives you an idea of how all of our programs are connected. If you want to go to the next slide too, that's incoming referrals, and the next one is outgoing referrals. It's kind of hard to read. So if you want to move on to the next slide.
Yeah.
Thanks. So some of the key takeaways, some of the services that we saw that are very well connected, WIC, Care House, Help Me Grow, GSC, the Oakland Health Department. There's a gap that stands out between home visiting survey data, that there are many home visiting programs out there, and that they don't know about each other. They might not know about each other's eligibility, what areas they service, what their curriculum is. So, you know, without knowing, smooth transitions don't always happen. But one of the great things about these home visiting programs is many of them go above and beyond to ensure their families' needs have been met. And I mean, dropping off supplies, cleaning supplies to these families. I mean, going through each of these meetings and talking to parents and talking to home visitors, I just want to reiterate, just, you know, during this whole pandemic, how amazing these people are, and making sure that the community is just connected with each other and helping each other out. The patterns in home visiting community are all that we can agree that there's a strong collaboration and an effort between them. Many of these people are in this position because it's a passion, and it really does show. If you want to move on to the next slide. So service delivery can be strengthened to better meet the needs of families by continuous education for all home visiting programs, continued collaboration between home visiting programs so that they can keep up to date on the new news and programs, and more information about home visiting programs to our community. One of the things I also wanted to call out again was just that many families did not know about these home visiting programs until they were approached by a program to enroll. There is, with other families, there's a hesitancy on being enrolled in these programs. You know, they think it's CPS, they think that their children will get taken away. They don't really understand what a support system it is and what it provides for these families. And then next slide. Assessing community readiness. Here we map between partners, and really we just wanted to see community knowledge of needs. If you want to move on to the next slide. We discussed and created dialogue of the 6 dimensions of readiness, so community knowledge of family needs, knowledge of home visiting, the community climate, the pursuit of equity, community leadership, and community resources. Next slide. So we kind of voted, you know, how ready we were on all of the 6 dimensions. It was voted moderate readiness. Some of the strengths that we saw was the focus and effort on each home visiting program to learn about each other, the opportunities for parents to ensure their voices are being heard. Home visiting programs are full, proving that there's a need that the community wants and uses. Equity education, a lot of the home visiting programs do talk about equity education. Making changes in teaching within the community is always a focus. Our county health department is a big supporter of home visiting programs. They have many years of proven funding so that programs are able to grow. As a home visiting community, we work together to get grants and help support one another. And our professional development training provides opportunities for networking for the home visiting community. Next slide, please. Some of the opportunities and areas that we saw for growth is that, you know, there are pockets of families with language barriers that might not be able to reach out as often. We might not be aware of their needs, and so that we won't be able to, you know, service them to what they need. Again, there's not enough families out there that know about these services, and it can sometimes depend on the community regarding their knowledge. So if their community doesn't really know about home visiting, they might not access it. And because there's a fear within parents who may select out of home visiting because they just don't understand the program or service. While support is felt, there was talks about while there was support felt within different early childhood agencies and programs, sometimes they felt that they didn't feel that the same with hospitals, churches, and doctors. And it might just be due to lack of knowledge of what home visiting really entails. But again, due to this COVID pandemic, we're now seeing more than ever the big inequities within our community families. We're seeing big inequities with education and problems in the communities we serve. Due to this new territory, I mean, there's big high technology needs that we're now seeing for children, and just now moving forward as far as making plans due to COVID, you know, we understand and we anticipate that the needs will start to grow, and we are just not seeing the aftermath just yet. Next slide. And I tried to run through this as quickly as I could. So if you have any questions or if you want any more data, there's my email address. And thank you so much for giving me the opportunity to share Oakland County's data. If you have any questions, let me know.
All right, we're gonna try and get Gaylada back. So I know she signed back on. Gaylada, do you want to try speaking?
Thank you, Jessica. That was helpful.
Very thorough, thank you.
Where is she? There's Gaylada.
Hi,
Gaylada.
Gaylada.
We're gonna try and get her on here. Gaylada, if you could actually call in with the phone number, I think that'll solve the problem. I'm not sure what's wrong with the mic today. So we're gonna scoot to Lisa, who's gonna present for Macomb County, Lisa Braddock at GDAC, and then Gaylada will come back to you. I'm sorry. All right.
Okay, Lisa.
Okay, I'm here. Can you hear me? Can everyone hear
Yes.
me? Okay,
Yep.
good.
Fine.
She said there was problems with the microphone, and that made me a little nervous.
And we are running out of time, so we're gonna ask you to, go fast.
No problem. I will speed through this as quickly as possible. Mine is not nearly as detailed as Oakland County's. And basically that is because GDAC was asked to come in pretty late in the process. The original organization that was doing the assessment for Macomb County had to drop out due to a lot of things going on with COVID. So we kind of came in to, try and bring it to completion. We were not able to do things like focus groups. So we didn't have the opportunity to really do full community engagement. We had to work with the data that we could get. And if you want to go to the first slide, Devin, I can kind of just give some high-level summary. The key takeaways for Macomb County. So like Jessica outlined for Oakland County, you look at the overall information and data for Macomb, it looks that they are, doing pretty well in terms of, similar demographics to the state of Michigan. And we've got, pretty decent or lower numbers, if you will, of infant mortality and so forth. But when you delve a little deeper and look by city or by zip code, you find that there's certain areas within Macomb County that are having some difficulty. And there are areas with residents that could greatly benefit from home visiting. And those particular areas, of course, are high poverty. They have high numbers of African American residents compared to the rest of the county. And for Macomb County, one thing that did stand out when stacked up against the rest of the state and even the rest of the country, there's some higher proportions of individuals who are born outside of the United States and people who speak a language other than English while they're at home. And so, of course, as expressed in the previous presentation for Oakland County, that certainly can limit in terms of accessing healthcare and accessing services, maternal child health services, insurance due to citizenship, or just the ability to speak English proficiently and communicate with providers. So next slide, please. Some additional takeaways. Now I'm hearing a little bit of an echo.
Yeah, so if everybody could mute themselves, I'd appreciate it. Thank you.
Okay, I think that's better. So additional takeaways. So the Macomb County has what's called the Baby Resource Network. It's a network of a lot of the various home visiting providers and community-based organizations that serve families with little ones and expectant mothers. And they have a lot of resources to help families in Macomb County. However, similar to what was said previously, a lot of families are unaware of these resources. So they're working to address that, and they're working to really do some deeper community engagement to really share those resources and really make it clear to families that help is available if needed. What came up was that there are some home visiting agencies that the quality isn't the greatest. And once a family has a poor experience with an agency, certainly word gets around. And word gets around not only to other families, but if, say, a community agency, a community-based or early childhood agency has a similar experience or heard of that, they're not likely to recommend or refer families to that particular home visiting agency. And it becomes that all MIHPs or all home visiting agencies are like this. And so that has certainly been a challenge. So while the resources, are in abundance, there's that barrier as well. And there's, barriers in terms of people working in silos and kind of being siloed off and not really coming together to really give full and complete comprehensive services to families and making referrals and connections across agencies. So those are, some weaknesses and barriers that in particular, the Baby Resource Network, they are aiming to work on. And it was expressed that the communities that have the greatest need in Macomb County are the communities that have the least amount of resources financially, and otherwise. So let's move on. What we did was, you know, of course, in analyzing that, we decided to kind of express the areas of highest priority graphically, because we know that there's some people who kind of understand some things visually rather than in reading a narrative. So we did this graphic expressing the areas that have, say, high or poor factors when it comes to outcomes or data when it comes to birth outcomes on the y-axis to the left, and on the bottom on the x-axis risk factors. So you see the upper quadrant that's highlighted in yellow on the right side. Those are the areas in Macomb County that have both high risk and poor outcomes. And those cities that are shown there, the circles, have to do with the size of the population. In case you're wondering, but those we've identified as the areas that have the greatest need and can benefit most from, you know, home visiting resources, and the energy and efforts should be kind of focused in those particular areas. Next slide. And this is just outlining, you know, how we came to those conclusions. So just for sake of time, I'll skip over that. So next slide, please. We were able to do similar comparing counties across Michigan. So we looked at some of the data there. And of course, Macomb County found itself in that upper quadrant again. We see Wayne County at the very, very top to the far right, along with Genesee, Saginaw, and Ingham counties. So we were able to kind of share that information with MDHHS as well. Next slide, please. And these are just different health factors, how they were measured. And we kind of chose, you know, red, orange, you know, kind of to highlight the importance of or whether or not this was something that was alarming or something that was a, you know, a good number and so forth. And Roger, I don't think is on the call. He's the one that did all of the analytics when it came to this particular slide. But if anyone, oh, you're here? Okay. I don't know if we have time for you to go into how you did that, but we can certainly give some response after the meeting. If there's some questions, I believe that we may be able to share some of these slides out. But highlighting, you know, based on the different health factors for each county, where, you know, Macomb County compared. The
only thing I'd share, Lisa, real quick, is we shared these slides, these graphs, with Bill Rodella, who's the director, the health officer of Macomb County, the health department. And Bill was very appreciative. He said that what we found was similar to what they found, and he's looking at incorporating the visuals kind of as a dashboard when they do community health needs assessments going forward. So that's kind of why we created it, because as Lisa said, a lot of people are visual, and it's interesting to see things jump out at you on a graph using a relative value 4-quadrant chart, and then this orange, green, yellow chart. So
thanks, Roger. Next slide. I don't think that one, the next slide is probably just more background and information. Yeah, I think that's, you know, how we came to the conclusions and giving some examples on, you know, air quality and children living in poverty and so forth. So I think, you know, it's safe to end it there just for the sake of time to allow Gaylada to give a summary on Wayne County. And like Jessica said, I'm also available for questions along with Roger and Devin, and I'll say Alethea and Iris. All of us worked together to complete this process.
Okay, thank you, Lisa. I'm gonna flip back to Gaylada's slides. Her and I are working on the sound piece. Gaylada, if you dial back in on your phone, but keep your computer muted, that should help mitigate any of that echoing, and then hopefully we can get you on here. Going backwards. Right. Let's see. She might be dialing back in. We'll just give it.
While we're giving Gaylord a chance to call back in, I just want to say we're going to certainly give her the time needed to talk about Wayne County, just because of the larger population that we have there, and to give you a sense of how closely all three of our counties are related in terms of needing more information to get out to the community about home visiting. We're going to adjust our schedule just a bit and give you a written version of items 5 and wrap up with announcements. And so we'll let you get out on time, but we will adjust. We have to be flexible, right? We're in public health. Okay, thanks.
Right. So it looks like we're.
Hello.
Caller 18, there you are. Give me just a second.
Turn your computer down to low volume.
Okay.
Yeah, turn the computer volume down, off.
Okay.
Oh boy. Sorry.
Well, virtual meetings are really great when everything works.
Yeah. Okay.
I don't think she can have her phone and computer.
Hello.
Okay, you're good.
It seems
Okay,
like
you can hear me,
Yes, we
but
hear
it
you.
sounds very echoey.
Yes, it does.
Yeah.
My computer is muted.
Okay, go ahead. Go ahead and let's see what we can get.
Oh, I really hate to do that with the bad sound, but let me just try and. Oh, the echo is driving me crazy.
Is there any way you can move the slides at least to recommendations and findings?
Yeah. Do we have
I don't have any. I didn't do the recommendations in that way. I was
or finding without the process, or it won't be quite as long?
I will submit something in writing. That's all I can say.
Okay. All right. Well, we will take your report and be sure that it is distributed fully. So I guess we can move on then. I'm really sorry about that, because as again, just restating.
Question, before you move on, could you just go, are there some conclusion slides?
Mm-hmm.
Could you throw those up?
Yeah, so are you speaking for Oakland County or Macomb
For Wayne County.
For Wayne.
Wayne County.
Let's see. So we had for Gaylada's information for Wayne County, these are sort of the information that we got. It seems like we don't necessarily have like a recommendations or conclusions precisely in her slides. Let me see. This is a web that is similar to what Jessica shared for Oakland County. Yeah. So, and I do want to say that we did kind of approach everybody a little late in the game to have them present. And so when we share the information after the meeting, we'll have Gaylada type some stuff up, and I'll include it in the meeting minutes and the notes. So this will help with the slide deck. But I think in terms of like the outcomes, and I don't necessarily mean to speak for you, Gaylada, but unfortunately we have a tech situation. So you can kind of see here the incoming referrals and the outgoing referrals in a similar manner to what Jessica did for Oakland County. So hopefully this helps answer your question, Dr. Holtrout.
Let me ask Gaylada if there were any significantly different recommendations that came out of Wayne County's work from what you've heard for both Oakland and Macomb. Perhaps you can chat those in for us. I do recall community knowledge being one of the issues that came up, but I don't remember them all by any means. So if you're able to hang with us and can put that in the chat, that might be useful. And as Devin said, we'll get the information out to you, to all of the memberships after this meeting is over.
Gaylada, can you hear us? But we can't hear you at all.
Yeah, I have her phone muted, just because of the echo problem that we experienced.
Is there any way she could just talk to us and at least tell us key findings without worrying about seeing the visual part?
Yeah, I think she may have dropped the phone off the call, and for whatever reason, the computer mic wasn't working, which is why we had her call in. So Gaylada, if you can chat something into the box, we can read it off.
Are you unmuted?
Yeah, she is unmuted. I don't know what the issue is. Unfortunately, I'm very sorry to everybody, and of course to Gaylada, for this issue that we're having here today.
Okay, well, I think we should just move on and put us some information in the chat, and we'll be sure to get the complete report out to everybody that's on the call. So why don't we move on? I really am sorry about that. Are there any questions about the other two presentations? Because we were holding questions until the end. There's a really wealth of information here.
Yeah. So it does not seem that there were any questions in the chat box, but if anybody had any questions, they want to unmute themselves, please go ahead and do so.
Okay, why don't we just move on? It's 2:47, and I want to go on with our updates and accomplishments and announcements. Alethea and Iris, we're gonna just kind of quickly bring everybody up to date.
Okay, you can go to.
Yep. Okay. Now I'm frozen. Really?
SEMPQIC this year. You may recall when we had our meeting in January, there was quite a bit of discussion about the need for implicit bias training for providers and within the community. And we actually talked about not only making that available to physicians, but to other types of providers. And we took that recommendation that came from our membership and helped to begin to develop some recommendations that we later sent to the governor. Please go to the next slide. And with COVID keeping all of us in place, when we had our April meeting, move to the next slide. Oh, no, I'm sorry. When we had our, back up one slide. When we had our advisory meeting in March with the home visiting advisory, because it was a virtual meeting, we heard some of the challenges that we were facing in this new environment, and that led us to have an April virtual meeting of our membership and hear about the additional issues that were coming up in working to provide service, as well as figuring out how to address the needs of our region within a pandemic setting. And so equity came out loud and clear. I think the membership began to talk about the need for an equity network, and we took all of that information and developed a letter that we sent to the governor's task force on racial disparities, and really tried to succinctly reflect the concerns and issues that came out of our membership. And we think that helped to influence the governor's proclaiming implicit bias training, the need for implicit bias training for providers. that came out as an executive order. We certainly think it helped to shape the executive order that declared racism as a public health crisis. And the whole concept of an equity network began to take shape as we thought about what we'd be doing in next year's work. Next slide, please. We had another virtual meeting in May and heard about additional issues that should be addressed that were coming up in your agencies and in working with the data that we were seeing coming out as a result of the impact of COVID-19. You remember there were testing gaps, children weren't being tested, people weren't being given the information, the full information they needed for testing, and we're often being discouraged about how to even access tests. And so we drafted a second communication to the task force, because it was really, the task force was designed to be a rapid response entity. And we thought this was the best way to get a rapid response, and shared the concerns that we heard directly from our community with the state through that task force. And we began to see some changes that happened in terms of being clear about the messages that were given to the community on what you needed to do to get a COVID test, who could be tested, where you could go. There were also some issues that were coming up related to our home visiting agencies about not getting reimbursed for telemedicine, when that really was the only way that they could provide service. And we shared that concern, and that was able to be addressed fairly quickly so that agencies could receive their payments for continuing their care through telemedicine. Next slide. Then when we had our June call, we promised at that point to share our work plan. We were working on our 2021 work plan, and we promised to share the work plan with our membership. We also, at that point, adopted greater involvement with MyAIM. And you heard Dawn talk about the MyAIM bundles and how we will be working with our birthing hospitals here in the region to make sure information about the work they're doing related to MyAIM is getting to the reporting entity, and so that they can get credit for the work that we know is going on. We also showed the video Toxic, a Black woman's story, that to the membership as part of our meeting. And that really raised a lot of discussion and comment from the membership. We heard really positive feedback from just viewing that video. You may remember it was less than 30 minutes. It really offers an opportunity for use within your agency, as well as within the community. And so we have moved forward to purchase the video for use. We also got requests from membership to have follow-up to view the video with some technical assistance. We also began to have some conversations about developing a toolkit for patients to be able to have those questions that they want to make sure they ask anytime they go into a doctor's office or see a provider. And very similar to what we've heard Dr. Norman outline in her work that's happening this year. So we've had that in our plans for 2021. Next slide, please. Other actions that we've taken this year, we've submitted several applications for additional grants, recognizing that the work that needs to be done in our region really is great and is greater than the funding that the state can offer at this time. And we're waiting now to hear back from the outcome for some of these applications. And you see the list here. I don't need to read them to you, but we're keeping our fingers crossed and hope to see that funding come soon. I think that is that my last slide. Next slide, Devin.
Yeah, we just had this one about health equity really quickly.
Okay.
If you want to talk about it.
The other thing that, my last comment is that during the year, we also began what we called a reading group, but wanted to use it as a way for our team, our internal team, to have our own professional development around health equity. And we read and discussed the New York Times 1619 project and talked about what the article was all about, as well as the implications of that information for what we're seeing right now, and really connected a lot of that information that really laid out the systems that were put in place 400 years ago that still exist in some form today that helps to influence the inequities that we continue to see. And we've got plans for continuing that kind of work. And I think we also offered participation in the reading circle to our membership if any of you are interested. And so with that, I'll stop. I'll let Iris talk about next year's plans and then we'll wrap up. Thank you.
Thanks, Alethea. Devin should go to the next slide.
Yep.
Quickly, there are, in our work plan for 2021, there are 4 objectives. I won't go through all the details, but go through the highlights considering the timing. We are going to continue with our SEMPQIC meetings in fiscal year 21. There will be 4 meetings scheduled. But in addition to those 4 meetings, we will also have 2 community feedback focus groups, to at least 2 of them, so that we can gauge whether or not we're having an outreach or any impact within the community. Go to the next slide. The other objective would be to provide representation at all mother-infant health and equity improvement plan meetings. SEMPQIC has always been integrally involved in supporting the state's plan for the maternal infant health and equity improvement plan, as well as we have worked within SEMPQIC in identifying specific objectives that we would like to pursue in equity work with in 21. Next slide. Objective 3 will be to infuse.
Ooh.
That the phone rings every time. We will continue to infuse maternal infant statewide initiatives into our collaboratives, and specifically, we have a commitment in working with MyAIM, as well as information that we report when we look at the FEMA work that occurs with the health department. Next objective. And then objective 4, we will continue our process improvement that we're currently doing with Healthy Baby at Home. At Hutzel at the Detroit Medical Center, we're also exploring opportunities to look at additional work with our FQHCs, as well as expanding to Oakland and Macomb County. And we're having some conversations with expanding to other health entities such as Ascension. The last slide. And we have newly added to the scope of our work a preventative block grant, specifically looking at our work in supporting the birthing hospitals around the MyAIM bundles, as discussed earlier. And so that's the essence of the committed work for 2021 2020-21. In addition to that, we're also exploring some other additional opportunities to further our equity work. And that's a quick summation of a lot of work that we're going to be engaged in 21.
Well, thanks, Iris. As you guys can see, there's a lot that we've done and so much more that we can do. And we're very pleased with the additional resources that we're getting from the preventive block and expanding our work with MyAIM, but also in the area of equity. There's going to be some major new work under the auspices of SEMPQIC. Is there anybody in the audience that needs to make an announcement? Anything that you want to share? You can do that now, or you can put it on the chat so we can be sure and include that in our notes of the meeting. So are there any announcements from any organizations?
This is just Devin. I'm just going to reiterate, and you probably all got this in your email, but our 2021 meeting dates have been announced. I am working to update our communications list right now, and you will be receiving calendar notices for all of these dates soon once the list is up to date. Additionally, later today, you're going to be getting this link right here in your email. We are working to do a very short evaluation. It takes less than 5 minutes to participate in it. This is information that we're going to include in our year-end report, and is focused specifically on the health equity components of each of our meetings. So when you get the email, please click the link and take the survey. Thank you.
Yeah, we're not scheduled to meet again until January, but because of some of the new funding that's come in, we're going to be flexible, and we may have to, we may be contacting you for a meeting or at least some discussion prior to January. And again, I want to mention the summit that's coming up, I think 22nd and 23rd, that many of you have registered for. We're finding that these virtual meetings can actually be very, 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 very effective. So hopefully we'll be seeing many of you there. So with that, I want to thank.
Can you hear me?
Oh, wow. Yes, we can hear you, Gaylada.
I changed computers, but that's okay. I don't want to interrupt your meeting. I just did not want this to be.
Yeah, because it's 3 o'clock.
Yeah, I got it. I just wanted to make certain that it was the computer downstairs and not this computer.
Yeah. One of the things, there was a lot of talking at this meeting, and it was good. It was excellent. But we were just talking amongst ourselves. We're going to come up with strategies to allow more interaction during even our virtual meetings as we look towards 2021. Because I know I participated in a lot of virtual meetings, just sitting and listening for 2 hours, without having some real interactions. It is not that easy. We'll be working on that. If you guys have any thoughts as to what we can do better, you'll get the evaluation. If you have any other thoughts of what you would like to see us do, or any processes you would like us to use, please share those with us. So again, thank you for tuning in, and you will be hearing from us between now and January as we get more information about where we're headed.
And Vern, and perhaps we can also put Gaylada on the calendar for whatever our next meeting is, so that we can further explore not only
but
what the interaction is between Wayne County, Oakland, and Macomb, and what's something that we might decide to add as a priority to interject.
Absolutely.
That would be good. I appreciate that.
That was really good. That'd be very good. And I just want to mention, having lived through COVID these past several months, moving forward, we've got to keep ACEs, adverse childhood experiences, and chronic stress on our table at all times, because our children are going to be experiencing the results of this moving forward. So again, thank you to everyone. This has been a good meeting.
Thanks a lot.
Okay, we need to sign off.
All right, thank you.
Okay, thank you.